Welcome to this Step 3 review on venous clot disease and blood thinners. This video is brought to you by Roadmap to Residency. Deep vein thrombosis, pulmonary embolism, and anticoagulation show up constantly on this exam, and the questions almost never ask you to simply name the diagnosis. They ask what you do next. Do you admit or treat at home? Do you start a pill or a drip? Do you bridge or not? And when a patient on a blood thinner starts bleeding, what is the very first move? Our goal today is not to reteach all of clotting medicine. It is to show you how these stems are built and how to attack the answer choices. Work through your question bank and a trusted review resource alongside this video because these patterns stick best when you drill many practice questions. Let us get started. Here is what we are going to cover today. First, we will work through treating a fresh deep vein clot and a pulmonary embolism by always reading for the next best step. Second, we will sort out the bridging question, meaning when you start a fast-acting injectable agent alongside warfarin, when a single direct oral pill needs no bridge at all, and when the stable patient can simply go home. Third, we will tackle the patient who is bleeding while on a blood thinner, where the order of your moves is the whole question. And finally, we will cover moving the stable patient from the hospital to outpatient follow-up. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read every clot vignette like a working physician deciding what to do next. Start with the last line of the question. That sentence tells you what is actually being asked, whether it is the next best step, the most appropriate test, or the best blood thinner to start. Once you know the question, go back and read the stem with that goal in mind, and you will stop drowning in detail. Then anchor on two things: the setting and the stability of the patient. A well patient with a small clot pushes you toward an oral agent and outpatient care. A patient with low blood pressure or a struggling oxygen level pushes you toward the hospital and towards stronger, faster treatment. Where the patient is and how sick they look will change the right answer entirely, so notice it every single time. Strategy 2 is the anticoagulation selection mindset, and this is where a lot of test takers stumble. First, match the agent to the patient. For most stable patients with a clot, the newer direct oral blood thinners are first line, and a well patient with a deep vein clot and reliable follow-up can frequently start treatment at home rather than being admitted. Reach for the single oral pill unless the stem hands you a specific reason to avoid it, such as pregnancy, severe kidney failure, or an antibody clotting syndrome, where the older injectable plus warfarin pathway is preferred. Second, bridge only when you must. Bridging means you overlap a fast-acting injectable thinner with warfarin until the warfarin reaches its target range. Because warfarin is briefly risky in the first days, here is the high-yield trap. The direct oral agents do not need that overlap at all. So if a question starts a direct oral pill and then offers an answer about also starting a heparin drip to bridge, that extra step is almost always the wrong choice. Strategy 3 is confirming the clot the right way, which the test weaves into many questions. First, let the risk level pick the test. When a clot is low likelihood, the stem usually wants the simple blood test that measures clot breakdown products. A normal result in a low-risk patient safely rules the clot out, and you do not order a scan. Save the leg ultrasound or the chest scan for the higher-risk patient where that blood test cannot settle things. Second, treat first when the patient is unstable. If the patient is high likelihood for a large pulmonary embolism and the blood pressure or oxygen is sliding, do not wait for the perfect picture. Start the blood thinner empirically while imaging is arranged, because the delay can kill. Third, beware the tempting overkill answer. The writers love to offer clot-busting drugs or a catheter procedure in a stable patient. Those belong to the patient who is truly crashing, not the stable one. In a stable clot patient, that aggressive option is the trap. Choose the proportionate answer, which is usually a standard blood thinner. Let us work through our first practice question, and this one tests how you treat a fresh deep vein clot. A 48-year-old woman comes to the clinic with 3 days of swelling and aching in her left calf after a long road trip. She has no chest pain and no shortness of breath. Her blood pressure, heart rate, and oxygen level are all normal, and she looks well. An ultrasound confirms a clot in a deep vein of the calf and thigh. Her kidney function is normal and she is not pregnant. The question asks for the most appropriate next step. Notice how stable she is, and notice that the stem went out of its way to tell you her kidneys are fine and she is not pregnant. Those details are there to point you toward a specific agent. Read the 4 options carefully and pick your answer. Then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. We have a stable patient with a confirmed deep vein clot, normal vital signs, normal kidney function, and no pregnancy, plus reliable follow-up. That is the classic picture of a clot that can be treated at home rather than admitted. Next, apply the rule. For this kind of stable patient, a single oral direct-acting blood thinner is first line, and a key point is that it needs no injectable overlap and no bridging. It lets her start safely as an outpatient. Now, eliminate the wrong answers. The clot-busting infusion in choice A is reserved for the unstable, crashing patient, so it is overkill here. The injectable thinner overlapped with warfarin in choice C does work, but it is the older and more cumbersome pathway, and the stem deliberately told you her kidneys are fine and she is not pregnant, which removes the usual reasons to choose it. Reassuring her and just repeating the ultrasound in choice D leaves a confirmed clot untreated, which is dangerous. The correct answer is to start the oral direct-acting blood thinner as an outpatient. Notice how matching the agent to the patient pointed you straight to it. Here is our second practice question, and this one is all about the bridging trap. A 60-year-old man is admitted with a pulmonary embolism. He is stable, his blood pressure is normal, his oxygen is fine on room air, and his kidney function is normal. The team plans to send him home the same day on a single oral direct-acting blood thinner that needs no laboratory monitoring. A trainee asks how to bridge his anticoagulation. The question asks for the most appropriate next step. The trap is hidden inside the trainee's question because it assumes bridging is required. Ask yourself whether this particular agent actually needs an overlap at all. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, know what bridging actually means. Bridging is when you overlap a fast-acting injectable thinner with warfarin for several days. You do this because warfarin is briefly risky when it is first started and takes time to become effective, so the injectable protects the patient until the warfarin level climbs into its target range. The whole reason bridging exists is that warfarin has a slow and unreliable onset. Now, why does the oral agent stand alone? The direct oral blood thinner in this question starts working within hours, so it simply does not need any injectable overlap. That makes the correct answer, choice B, no bridging is needed. The oral agent is complete on its own. Look at why the others are wrong. Overlapping an injectable in choice A and adding warfarin in choice C both belong to the old warfarin pathway, not to a direct oral agent. Placing a filter in the large vein in choice D is reserved for patients who cannot take blood thinners at all, and it is not a way to bridge. The correct answer is that no bridging is needed. Whenever a stem starts a direct oral agent and then dangles a bridging step, that step is the trap. Let us talk about time management because this exam is a 2-day marathon, and pacing is where many strong test takers lose points. There are 480 questions in total, spread across 2 days, with day 1 carrying more questions than day 2, and each day broken into timed blocks. That gives you a little over 1 minute per question on average. First, know the clock and the pace, and practice working at that speed in your question bank so that the rhythm feels automatic on test day. Second, learn to flag, move on, and bank time. Clot and blood thinner vignettes are often long, stuffed with lab values, imaging results, and kidney numbers. If a single question has stalled you for more than about 90 seconds, lock in your best guess, flag it for review, and move forward because letting one dense clot stem swallow the time of 3 other questions is how blocks go unfinished. Bank the spare seconds you save on the quick questions and use your scheduled break time wisely so you arrive at the second day rested and focused. Smart pacing protects every point you have earned. Here is our third practice question, and it is about a patient who is bleeding on a blood thinner. A 70-year-old man on warfarin for a prior pulmonary embolism comes to the emergency department vomiting bright red blood. His blood pressure is low at 80/50, his heart rate is high, and he looks pale and clammy. His clotting time is far above the target range. The question asks for the most appropriate first step. The word first is doing a lot of work here. When a patient is unstable from bleeding, the order of your actions is the whole point of the question. Several of these options are things you will eventually do, but only one is the correct first move. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, resuscitate, then reverse. This patient is unstable from active bleeding with a low blood pressure, a fast heart rate, and a pale, clammy appearance. Whenever a patient is unstable, the very first step is always to support the circulation, which means intravenous fluids and starting blood transfusion at once. That makes choice A the correct first move. Stopping the warfarin and giving a reversal agent absolutely need to happen, and in practice they happen almost in parallel, but the question asked for the first step, and you stabilize the bleeding patient first. Now, why do the other steps wait? Vitamin K alone in choice B works far too slowly for a crashing patient, which is why in real resuscitation it is paired with faster-acting clotting factor products rather than used by itself. So vitamin K alone is not the first move. The upper endoscopy in choice C is genuinely needed to find and treat the source, but only after the patient has been stabilized, never before. And resuming warfarin in choice D, even at a lower dose, during active life-threatening bleeding is exactly the wrong direction. The correct answer is to give fluids and transfusion first. Remember the rule, stabilize the patient before you chase the diagnosis. Here is a high-yield pearl that pulls the management thread together, and it is how you move a clot patient from the hospital to home. Before discharge, confirm the plan. The stem signals a patient is ready for home when the vital signs are stable. The oxygen is fine on room air, the pain is controlled, and there is no active bleeding. Make sure the patient can actually obtain and afford the blood thinner and understands how to take it, and make sure there is a reliable way to follow up. That follow-up detail is exactly what the test wants you to notice before you pick the discharge answer. Then, think about care at home and arranging follow-up. The strongest answer usually includes early clinic follow-up to check the blood thinner and to decide how long treatment should continue. For a clot triggered by a clear, temporary cause, such as recent surgery or a long trip, treatment typically runs about 3 months. For an unprovoked clot, or one with an ongoing risk, therapy may be longer or even indefinite. So when two answers look reasonable, choose the one that arranges follow-up and continues protection, not the one that simply stops the drug too early. That wraps up our review of venous clot disease and blood thinners for Step 3. Remember the core ideas we covered today. Read every clot vignette like a working physician deciding what to do next, and start with the last line of the question. Match the blood thinner to the patient, favor a single oral agent when nothing in the stem forbids it, and remember that the direct oral agents never need bridging. When a patient is bleeding on a blood thinner, stabilize the circulation first, then reverse, then find the source. And when the patient is stable, move them to outpatient care with early follow-up and a clear plan for how long treatment lasts. The best way to lock all of this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.